Good evening, everybody. Welcome to the ADS Connect. Welcome to the activity organized by the Emirates Diabetes Society. And today we're going to have the part 4 episode of hypertension in depth. I would like in the beginning to thank Dr. Alauddin Bashir from Dubai Hospital for organizing this activity. This is the 4th episode of it. And the focus this time will be on hypertension and cardiometabolic. We have 4 excellent speakers, 3 from the national level and 1 international speakers. At the beginning, welcome to this episode. And I would like to mention that this webinar is CME accredited by the Ministry of Health and Prevention on 1.5 CME hours. After this webinar, later you're going to receive email. We need to get your feedback regarding how to improve this webinar better and what's your impression about the webinar. And following that, you're going to receive your CME hours. This webinar will be recorded on the website of the Emirates Diabetes Society and will come to the 4th part 4 episodes on hypertension. I would like to welcome our first speaker. And before mentioning that, there will be, if you would like to put any questions, the Q&A sessions will be at the end of this webinar. You can put your questions in. We'll go through them one by one. And then during this talk, there will be a number of polling questions. Please key in your comments or questions, and then we'll respond to that. Our first speaker is Dr. Hani Sabur. He is a consultant cardiologist and electrophysiologist at Clifton Clinic, Abu Dhabi. He has established a comprehensive pulmonary hypertension center and pulmonary hypertension registry at SKMC, and is a leading in terms of SAHA hypertension, pulmonary hypertension guideline writing team to complete the SAHA clinical practice guideline in the management of pulmonary hypertension. Welcome, Dr. Hani, and the title of the talk will be focusing on hypertension and cardiovascular system. Please unmute your microphone and start presenting. Thank you so much.
Thank you very much, Dr. Juma. It's really a pleasure and a privilege actually to be part of this very important set of meetings. And I think looking at all the comorbidities in hypertension, diabetes, cardiovascular disease, I think these are all such important topics to talk about. So I think we'll break this talk up into multiple different parts, but I think the most important thing we want to talk about is prevention of cardiovascular mortality and prevention of morbidity during COVID-19, the central role of RAAS blockade in hypertension, and also from hypertension to preventable organ damage. So during COVID-19, we've obviously had lockdowns and we've tried to avoid unnecessary contact, but it's also important to remember that patients with CVD or risk factors such as hypertension, diabetes, or smokers are more likely to die of COVID-19 complications because of their underlying cardiovascular disease. And the idea that we have to focus on prevention is very important because we've seen more patients come in with severe ST elevation MI, cardiogenic shock. So acute heart failure, acute coronary syndromes, and other cardiovascular syndromes, we need to tell the patients to come in early, but also focus on the prevention of the disease in the beginning. So we all remember this whole strange controversy that came up from a small letter to the editor about ACE inhibitor and COVID-19, which turned out to be completely false. And after a lot of debates, finally, this is the Journal of Hypertension, no evidence to abandon RAAS blockers. So even our approach to science was modified to COVID-19, and particularly in the hypertensive patients, this is a critical intervention therapy. In fact, it turns out that the RAAS blockade increases soluble ACE2 and provides a decoy to COVID-19 virus. So this was a false news, actually, if it was there. And of course, all the societies finally came up with the idea not to stop ACEs, ARBs, or ARNI in heart failure or hypertension during COVID-19. Now, cardiovascular disease is still a major cause of death and still continues to do so, greater than cancer and all infectious diseases. And if we start from insulin resistance, dyslipidemia, and hypertension, the core 3 risk factors in modern society, we have endothelial dysfunction leading to atherosclerosis, coronary disease, ischemia, acute coronary thrombosis and ACS, infarction with loss of muscle, ventricular dilatation, heart failure, and end-stage heart disease. So it is critically important to focus a lot of our attention here on this primary prevention aspect, from smoking, dyslipidemia, and hypertension, of course, as well as diabetes and insulin resistance. So hypertension drives a lot of the cardiovascular events, and in well-developed countries, as well as developing and mid-range countries, it is a very large burden of hypertension. Up to 50% of patients are hypertensive. And blood pressure accounts for the majority of cardiovascular deaths. In fact, more than tobacco and cholesterol, if you take that in aggregate. Now, 2 important things to realize: that every 20 over 10 millimeters increment of systolic and diastolic blood pressure, double the risk. So this is 135 over 85, double the risk. 155, 4 times the risk. 175, 8 times the risk. So these small numbers are not really small in terms of cardiovascular outcome. So clearly these are linked. Hypertension, dyslipidemia, diabetes, smoking, all of these lead to endothelial dysfunction, oxidative stress, and directly lead to plaque rupture and cardiovascular disease. The attributable risk for morbidity and mortality in terms of cardiovascular disease from hypertension: 62% of stroke, 56% of CKD, 50% of heart failure. So this is a massive amount of morbidity that is driven by coronary artery disease. It shortens life by 5 years and costs at least $46 billion in terms of hospital costs of untreated hypertension. And if you look in the United States, this is data from a few years ago, the 80 million Americans with hypertension, 41% of adults will have hypertension. It's leading to about a third of patients having, a third of those untreated patients end up with reduced GFR. So this is really not a small number at all. And 36-fold increase in all of these cardiovascular events. So 10 by 5 millimeters of mercury is a very significant increase of all of these ischemic cardiovascular mortality events, of course. Now, the reverse is also true. Decreasing blood pressure by 2 millimeters of mercury decreases events by 7% reduction of ischemic heart disease and 10% reduction of stroke. So every little bit counts. And I think we have to be very rigorous about our definitions. There was a problem in that prior to 2015, the guidelines were very conflicting and contradictory, very difficult for a primary physician or certainly a patient to follow. And there was no specific consensus. If you look at these various 2014 guidelines as to what was the number, even what was the target, what was the treatment. So in fact, this actually started to come up into the lay press and Time magazine and non-clinical journals, that it's really very confusing. So we start now with a case to highlight cardiovascular risk, because in fact, cardiovascular risk drives our treatment algorithm now, and we'll review the 2018 European Society guidelines. So you have these risk factors. And in fact, when you look at these additional risk factors, this diabetes, established coronary artery disease, presence of hypertension, family history, obesity, and elevated cholesterol, all of these tie into the fact that a patient with hypertension or one or more of these additional factors probably needs earlier treatment or adjustment of therapy. The classification of blood pressure now, based on the current 2018 ESC guidelines, is much more rigorous. A normal blood pressure is 120 over 29 and 80 over 84. And when we talk about hypertension, the European guidelines talk about a 140 over 90 for grade 1 hypertension. This modifies itself if a patient has risk factors. And if you look at the assessment of cardiovascular risk, the presence of risk factors here, even with a grade 1 hypertension, would inspire you to start treating very early. So it's not really just about the number, it's the number and presence of risk factors. Now think about how many patients we've seen this week in the clinic that have hypertension, but also have dyslipidemia, also have hypercholesteremia, also have family history, also have diabetes. The vast majority will fall into these two buckets here. And the additional thing you should do now if you see a hypertensive patient is to look at their cardiovascular risk category using the score system or whatever other scoring system you like to use, because if you have an elevated score or any of these identifiable risk factors, such as diabetes, LVH, or CKD, then you need to treat them early because they're high risk, just like you would approach lipids. So these are additional things that come up during the assessment: risk, BMI and waist circumference. Family history is very important, atrial fibrillation, left ventricular hypertrophy, and CKD. So these are cardiovascular risk factors that are built into the equation for hypertension treatment. In addition, some people like to use the ACC risk calculator. If you have a high cardiovascular risk due to cholesterol, remember that blood pressure is an integral part of the risk calculator as well as your smoking and diabetes risk factors. So I hope it's clear that you now have to integrate both risk calculators in order to reach the same decision, whether it's for lipids, for diabetes, or for hypertension. So if you take a patient like we just saw here, who's a patient male, 59 years old, has high cholesterol, low HDL, blood pressure 140/87, diabetic and smoker, this is the risk, 42% 10-year risk. You would say, well, what's the big deal? It's just a little bit of blood pressure, a little bit of cholesterol. It's absolutely a ridiculously high risk of cardiovascular events. And this patient also has established CVD and diabetes. So you can actually change their optimal lifetime risk with treatment to 5.2%. So this is actually because these are multiplicative effects. They're not additive. So with hypertension, dyslipidemia, and smoking, the risk is 6 times higher. That's 600% higher than any one of these risk factors alone. So even stage 1 hypertension, the modest elevation of blood pressure, carries a substantial risk of cardiovascular disease. So with 140/90, 63% lifetime CVD risk. CVD occurs 5 years later. And if the blood pressure is less than that, it's 46% over their lifetime. And look at the number of ischemic strokes, heart failure, and MI. Really very impressive for just a slight elevation, what we call stage 1 hypertension. So as you see the patient from a clinical standpoint, apart from the blood pressure, remember males, age, smoking, dyslipidemia, impaired glucose tolerance or overt diabetes, obesity, abdominal circumference, very important vital sign, waist circumference 102 in males and 88 in females. This is a metabolic equivalent and a very high risk patient. Plus family history of premature coronary heart disease, males less than 55 and females
we
less
lost
than
the
55.
voice, Turhani.
Yes?
I lost your voice.
I can hear you quite clearly.
I don't know. Could you go back over this slide again?
Certainly. Yeah. So when you look at the factors that clinically you see the patient who has stage 1 hypertension, consider if they are male, if they are slightly older than 55, smokers, dyslipidemics, fasting blood glucose elevation or abnormal glucose tolerance, obesity, or either defined by BMI or waist circumference or family history. This changes their risk entirely, and you may need to start treatment even if they're stage 1 hypertension. This is a critical point, that these clinical risk factors have to be integrated in your early treatment decision. Additionally, it's very important to look for asymptomatic target organ damage. So during physical examination, a wide pulse pressure, more than 60. If you do an ECG, and this is mandatory in a newly diagnosed hypertensive or annually in a hypertensive patient, LVH on ECG. How about LVH on echo? If a patient has a bruit, look for the carotid thickening or presence of plaque. Ankle brachial index is a specific risk enhancer that is required in smokers, required in patients with diabetes as a part of their screening program. The presence of CKD is a marker of target organ damage and is even in stage 1 hypertension, GFR 30 to 60 is a marker for early treatment. The presence of microalbuminuria as well, or urine albumin creatinine ratio, all markers of target organ damage, and this moves the patient to a very high risk group, even if they have stage 1 hypertension. So it's very important to look for these in the day-to-day practice. You can't just measure the blood pressure and walk away. If they have established CV or renal disease, that's a completely different story. Now there's secondary prevention. So this is historical data. Cerebrovascular disease, any history of stroke, TIA, or hemorrhage. Coronary heart disease, MI, angina, revascularization, or CAPG. Any history of heart failure, including preserved ejection fraction. Peripheral artery disease, severe CKD and proteinuria, and of course the presence of retinopathy due to hypertension or diabetes or otherwise. So to highlight this point, we're going to run through a case. It's a 55-year-old male not known to have prior medical condition. Annual checkup on his BP was found to be elevated on 2 readings, 155/88, some labs. So what tests would you like to do to work up this patient? A lipid profile, fasting glucose, serum creatinine, CBC, or some combination of the above? So there's a polling question. We'll just have 15 seconds to run the poll. All right. So absolutely, you need to do, definitely have to do the serum creatinine. You definitely need to do the lipid profile and the glucose because that impacts your treatments. So the glucose was 5, kidney function is normal, creatinine is 60. Patient has a very high LDL and no protein in the urine. But what about the ECG? So what do we see here in the ECG? The patient has concentric LVH, and you can see very large voltages here and strain pattern, may even have ischemic heart disease. So since the patient is actually diagnosed to be hypertensive, at this point, with the investigations we've just seen, what modality should be initiated? Non-pharmacological, pharmacological, both, or neither? So again, we have a polling question. And we have 15 seconds for the answer. All right, so the answer, of course, is both. And what agents would you start? RAAS, CCB, diuretic, beta blocker, combination. So the reason why we need to start combination therapy in this patient is twofold. First of all, the patient already has evidence of target organ damage. They have LVH, right? Even though they are not symptomatic, they have LVH. And also, because we also know that they need to be on an ARB, the other thing that you should have noticed also is the patient has hyperlipidemia and therefore needs to be managed from that perspective as well. So control of hypertension is always a worldwide problem. Most patients are uncontrolled, even if they're started on treatment. And many reasons for that, including compliance and adherence, absence of synergy, and too low dosages. And unfortunately, even in patients with CKD, many patients also have uncontrolled hypertension, even when the stage is not noted. The presence of CKD, in addition to obesity, diabetes, dyslipidemia, leads to progression of atherosclerosis, valvular, and LVH. And the presence of severe CKD also leads to chronic inflammation as well as volume load. So CKD and cardiovascular disease are interactive. As well, we know that the GFR leads to other changes such as metabolic acidosis and hyperuricemia, as well as vascular changes. Now, what about in the diabetic patient? There's an entity called diabetic cardiomyopathy. So this is the presence of abnormal myocardial performance without coronary artery disease, without severe hypertension, and without valvular heart disease. And this is a real finding. This is from pathology, autopsy specimens from 1972, perivascular fibrosis and intramuscular fibrosis. And the clinical findings, and this is a patient that you would typically see in your clinic. They may in fact be early diabetics as well. Asymptomatic diabetics with a slightly abnormal ECG, often who had stage 1 hypertension. Tissue Doppler showed diastolic dysfunction in 63% and abnormal transmitral filling in 46%. The findings were normal or low QRS voltage and non-specific changes. And this finding is actually due to fibrosis and scarring with left ventricular hypertrophy plus left atrial dilatation. So this is the echo finding that is seen in many diabetics, and it's always presumed to be due to hypertension, and it's often not just the case. And the reason is there's more myocytes, there's loss of myocyte loss, there's myocyte hypertrophy, abnormal proteins deposit among the cells, and there's insulin resistance, which can also lead to atrial fibrillation. There's also activation of angiotensin 2 and endothelin 1, which are pro-inflammatory and hypertensive promoting, and collagen synthesis and deposition with fibrosis, which ultimately leads to increased scarring within the myocardium, which progresses over time even in patients with early diabetes and pre-diabetes. And one of the other things that have been noticed in more recent studies is something called longitudinal strain. So in diabetic patients, even in patients with less than 5 years of diabetes and no coronary artery disease or heart failure and normal EF, they had a reduced finding of global longitudinal strain, even as the earliest finding in their disease. And in fact, the use of some of the SGLT2 inhibitors have been shown to improve this global strain within 6 months of treatment in type 2 diabetes. And it's really important to realize that the diabetic heart is completely different than the healthy heart in the earlier stages because of left ventricular hypertrophy, which is promoted by insulin resistance and hypertension and remodeling and changes within the extracellular milieu. So coming back to the ESC, ESH guidelines, which many of us have adopted from 2018, again, these are the cutoff points for treatment. Grade 1 hypertension, 140/90. The American guidelines are slightly more rigorous. They go to 135/85. But the most important thing is risk assessment. And this is what I've been trying to highlight in my talk here, that it really doesn't matter if you have a high normal blood pressure or grade 1 hypertension. If you fall into these patients with established disease or asymptomatic disease, target organ damage, or multiple risk factors, then these red squares indicate that you're going to initiate pharmacological and non-pharmacological therapy, and probably in combination at an early stage. It's driven by risk rather than by the blood pressure number, because even a 10 millimeter of mercury difference increases the risk of cardiovascular disease by several fold. So the summary of this is, if the patient is a high-risk patient with established CVD, you would initiate at 130/85. Immediate introduction in high-risk CV patients with 140/90. Immediate introduction of hypertensive therapy in grade 2 and 3 hypertensive patients because of the blood pressure, and low to moderate risk patients with lower levels of blood pressure after dietary and lifestyle interventions. This is really sort of the overall summary. But I'm going to point out to you that most of the grade 1 hypertensive patients we see here are actually patients with either overt insulin resistance, diabetes, some degree of CKD, some degree of target organ damage, some degree of ECG abnormality, plus smoking, dyslipidemia, and family history. And in general, the guidelines recommend early combination therapy, always including ACEs or ARBs. And generally, the ACEs or ARBs are combined with a CCB or diuretic, depending on the phenotype. And the patients who are quite old and fragile, monotherapy might be considered. And triple combination within the next visit, in other words, within the 2 to 3 month visit, with again the central role of ACEs or ARBs. And not to forget the resistant hypertension, where spironolactone and additional things, testing for sleep apnea and secondary hypertension, is recommended. The fixed dose hypertension has become a big role, has a big role in cardiovascular disease prevention, largely because of the compliance issues and the recommendations from the blood pressure control studies. These are a number of blood pressure control studies showing that most patients will require at least 2 to 3 antihypertensive drugs in order to achieve the targets. And these targets are, of course, difficult but very important to achieve in the long term. And as we mentioned before, the guideline consensus is central role of RAAS blocker and then CCB or diuretic or triple therapy in the end. And with that, I'll conclude my presentation and hope to take any questions. Thank you very much.
Many thanks, Dr. Hani, for the excellent talk. Please, if you have any questions, key in your questions, mention the speaker you'd like to answer a question. And we're going on to our second speaker. Our second speaker is Dr. Mohammed Hassanein. He's a consultant endocrinologist at Dubai Hospital. He's the Deputy Director of Postgraduate Diabetes Education at Cardiff University, Wales, in the UK. And he's the chair of the DAR International Alliance. And the title of his talk will be focusing on the dietary modification in hypertension. Welcome, Dr. Mohammed Hassanein.
Thank you very much, Dr. Juma. Thanks for the kind introduction, and thanks for the EDS for the invitation for such an important program. I'd like to thank my friend and colleague, Dr. Ala, for planning this exciting group of lectures on hypertension, such an important topic. So it's always my delight to follow Hani, as many of my points will be covered. I hope today not many of them will be covered, but my remits for the talk is related to hypertension and diet. What should we eat? My interest in the topic is, in fact, goes back over 15 years as I completed a master's degree in philosophy in human nutrition. So in essence, I'm double qualified to be a nutritionist as well, although I think I will stick to my job of endocrinology. This is a photo of the graduation with my parents, rahmatullah alayhum, and my wife. So the objectives of my presentation will to look into a brief introduction, which I will make it very brief, as most of it is covered now. And then we'll look into the understanding of the different types of food in relation to blood pressure and hypertension specifically. And then we also address the impact of salt on blood pressure targets, and finally trying to look into how can we convert the theory into practice from our everyday life. So the first part, I think Hani has covered this point, but I would like again to remind you of thinking of the main health issues. If you want to put them into sequence, this is not a polling question. I want you just to think about it. What will be the highest problem for health, followed by the second, third, fourth, and fifth? While you're thinking, I'll share with you the information that I think Hani has already alluded to, which is hypertension is the first cause of mortality globally, followed by smoking. Third is diabetes, and then the issues related to physical inactivity and being overweight. So hypertension indeed is quite a problem. The data from Wakaya survey, the health survey that was done a few years back, published in 2012, which looked into Emiratis of the age of 18 upward, with a mean age of 36, the prevalence of hypertension was 23% of the population. Although, as you can see, the mean age is quite low. So it's a problem that is very prevalent in our community, and in diabetes specifically, the health benefit from reducing systolic blood pressure is far much more than reduction of glycemic control. So let's go to the second point of the understanding of the relation of the different types of food in hypertension. So the question that Ala, when he's planning his program, asked me is, what types of food would be appropriate for a person with diabetes and hypertension, or just hypertension? And when you look into the NICE guidelines, they stress very importantly on the lifestyle, as well as also on the home blood pressure monitoring. That's important for all of us to remember. And they specifically say, offer lifestyle advice and continue to offer it periodically, and advise who want to self-monitor to use home blood pressure monitoring, because it's quite helpful. The same would apply from the European Society for Hypertension and European Society for Cardiology, where they also stress the importance of motivation and education and simplifying things. So when you think of hypertension, there are genetic causes, there are social causes, and there are environmental causes. And of course, all of them overlap. Today, I will address some of the environmental causes. So what does the ADA consensus or position statement say about diabetes and hypertension? So the lifestyle management should start for a person with blood pressure in anyone above the systolic blood pressure of 120 or diastolic of 80. What should we do? We should advise them about weight loss, as well as the DASH diet, specifically thinking of sodium reduction, increasing potassium intake, increasing fruit and vegetables, cutting down on alcohol for those who drink alcohol, and increasing physical activity. So the DASH diet. The DASH diet is an abbreviation of the word dietary approaches to stop hypertension. Now, foods that are low in saturated fat, in total fat and cholesterol, but they are high in fruits, vegetables, and low-fat dairy foods are considered to be the main staple of the DASH diet. So, example, whole grains, poultry, fish, and nuts, and these you can have them on a regular basis. Small amounts of low-fat red meats, sweets, and sugared beverages would also be recommended. Increasing potassium, calcium, and magnesium, as well as fiber and protein, would be recommended. So when you look into the pyramid of the DASH diet, the base of it is physical activity. The second level is the grains, and that is recommended to be whole grains. Whether this is pasta, bread, or rice, they try as much as possible to have the type that is grains. Fruit and vegetables are daily, 4 to 5 portions a day of each of the fruit and the vegetables. Having daily low-fat free or fat-free dairy products is also okay, and having fat oils of a small amount. And I will show you now what is one serving. They recommend no increase of sodium intake more than 2,300. So how frequent should we have sweets? Small amount of sweets, not daily, and small amount of nuts that are not on a daily basis. Unfortunately, as we all know, our culture is daily sweets and daily nuts and daily lots of other food that is maybe tasty, but with concern. So when you look into the plate of the DASH diet, on a daily basis, a person can have 7 to 8 serving of grains, such as, what is a serving? 1 slice of bread, or 1 cup of cereal, or half a cup of cooked rice or pasta. And you can have 7 multiplied of these. So if you like to eat rice and you don't have, you can mix between rice and bread and cereal, and still you will have reasonable amount to fill hunger. Fruit and vegetables, a cup of raw vegetables or half a cup of cooked vegetable is 1 serving. We are allowed 4 to 5 for the DASH diet. One piece of fruit is one serving. We're allowed 4 to 5 pieces of fruit a day. Now, you might say that all of this is too much for a person with diabetes, and hence our involvement of how can we match the type of diet for a hypertensive diabetic. And all of the information are here, and people can find this information in abundance online. What is the evidence that DASH diet is helpful? Well, the first study was published 23 years ago in the New England Journal of Medicine in a study of 460 persons with a mean blood pressure systolic of less than 160 and a diastolic between 80 to 95. For 3 weeks, they had control diet, which is the typical USA diet, which is actually not so healthy, as it is low in fruits and vegetables and dairy products, but high in fat content. And then they were randomized to receive 8 weeks of either the control diet or the diet rich in fruits and vegetables, or a combination of diet that is rich in fruit, vegetables, but also low fat dairy products with reduced saturated and total fat. The sodium content in this study was sustained with no increase. And as you can see, what constituted the DASH diet, which was the combination diet, had a very good systolic blood pressure reduction from not such a high mean, and equally a very good diastolic blood pressure reduction in comparison to the control diet, which is the everyday diet an American was having in the USA. When you look into the details of how much the blood pressure was reduced, in people with hypertension, systolic was reduced by 11 millimeters mercury and diastolic by 5.5. Now, many antihypertensive do not reach that level. And in fact, the person did not have any extra costs or any side effects of a medication. In fact, they saved money by eating healthier, and also they saved themselves from having extra cost for antihypertensive. So this is the information that we have of the efficacy of the DASH diet. What about the Mediterranean diet? Well, many of us belong to Mediterranean regions, and we are familiar with the food in the Mediterranean, which is lots of vegetables. Meat is there, but not necessarily in excessive amount, not as we sometimes have open buffets and a big portion of mashawi and so what have you. Dairy products such as the Greek yogurt and the plain yogurt should be there, and a variety of cheese. Seafood twice a week. I personally would welcome that diet at any time, and specifically the type of food and fish that is rich in omega-3 fatty acids. A vegetarian meal at least once a week, and using good fats such as olive oil and other types of sunflower oil and other oils such as in avocados and nuts, and switching to whole grains as well. The whole grain for bread, the hummus, lentils, and so forth. And finally, for desserts, we need to think of fruits as a replacement to classic ice creams and savory cakes and biscuits. So what is the evidence for the benefit for the Mediterranean diet? Well, a systematic review and a meta-analysis that looked into 6 randomized controlled trials eventually came up with a clear indication that Mediterranean diet is also helpful for people with hypertension and can lower the blood pressure in at least 6 randomized controlled trials. When it comes to weight loss, people are not clear whether they should have the Mediterranean diet, the low-fat diet, or the low-carbohydrate diet. And this particular study, published in 2008, that ran over 2 years, clearly show that the low-carbohydrate diet is better for weight loss in comparison with a low-fat diet. The Mediterranean diet was very close to the low-carb diet when it comes to weight loss as well. Not in the beginning. The low-carb is the best initially, but on the long term, because low-carb is difficult to sustain. As you can see, some people do it and then it weans off, while the Mediterranean diet is sustained because it's a type of food that you can have for life. So moving on from the type of diet, if I would summarize, I've shown you that the DASH diet is quite helpful. The Mediterranean diet is also quite helpful. And for weight loss, we have a variety of different options. Specifically, the low carb and the Mediterranean diet are better for weight loss compared to the low fat diet. So when it comes to salt, we have good salt and we have bad salt. Let's start with the bad. And I would like to ask you to think mentally, how much daily sodium intake should any of us have? Is it as low as 750 or as high as 5,000 or in between? And should we have lower and lower salt, or is good, or there's a kind of a cutoff amount that below it is not so helpful? Well, the information from the American Heart Association, it should be no more than 2,300 milligrams of sodium per day. Ideally, no more than 1,500 per day for most adults. And that's quite important for all of us to remember. When you look into the American Diabetes Association recommendation for hypertension management in their position statement, they specifically say that sodium reduction could be helpful, could reduce blood pressure by 5 millimeters mercury and diastolic by 2 millimeters mercury with a moderate sodium reduction, not excessive, moderate, from an average 4,600 in an average person in the US to the 2,300. Now, as I mentioned earlier, if we want to be ideal, or if the blood pressure is a bit too high, you need to not exceed 1,500. There is a dose response to the sodium reduction. The lower the sodium, the lower the blood pressure would be. And that's why very low sodium intake could be harmful. And even in people who are on antihypertensive, cutting down on sodium and salt is quite helpful. The weight, every kilogram of weight reduction reduces blood pressure, systolic blood pressure, by 1 millimeter mercury. My concern is we're now glorifying salt. Salt as a name becomes a trend and a brand for fancy restaurants. And not only salt in food that you normally think I will add salt in, you can even have some salt in ice creams and in chocolates. So salt is moving to uncharted territories. I would not imagine when I was young, I will go to a restaurant called Salt, because that would not be something appealing. But now we have these fancy things that becomes like a fashion and people follow it. Circulation published this a very important study last year, looking into 3 interventions that can save 94 million lives globally. The first one is increasing the accessibility to antihypertensive up to 70% of those who have high blood pressure. The second is reducing the sodium intake by only 30%. And the third is eliminating intake of artificial trans fatty acids, and the 3 together within 25 years can save 94 million lives. Here is the information. So if you do the 3 together, you reduce mortality in women by 42 million and in men by 53 million. If you look into salt and antihypertensive, that's about 35 million in women and 45 million in men. This is the interesting point. Salt reduction by 30% is equivalent in mortality reduction to accessibility of antihypertensive across the globe for 70% of the population with high blood pressure, whether that is in men or in women, as you can see here. So salt reduction is very, very important. So we have seen the impact of salt reduction along with antihypertensive. The question now is, so here you saw the impact of combining both salt reduction and hypertension treatment accessibility. Now, in this particular study, they are answering the question, what about if you have the DASH diet, but also would include low sodium? And this was quite an interesting study that is published in the Journal of American College of Cardiology in 2017. And I will show you the results of this because they randomized people to control or DASH diet and randomize them according to sodium intake, according to the level of sodium intake from 50 to 100 to 150 millimoles per day for the calories. So here is the information of the DASH diet versus the control. In people at high sodium level, if they are hypertensive, the reduction in blood pressure is systolic blood pressure is minus 10 millimeters mercury. If they are on low sodium, it's minus 14. So quite impressive level. And here is the information from the study. In red is the low sodium as well as DASH diet. And in blue is the high sodium control diet. So systolic blood pressure would reduce by nearly 21 millimeters mercury in someone following the blood pressure, the low sodium diet as well as DASH diet if they have high blood pressure above 150 millimeters mercury systolic, and they would reduce their diastolic by nearly 8 millimeters mercury if their diastolic is above 9. The lower the blood pressure, the lower the increment, but still with very decent reduction, because that will take the person from the bracket of 140 to the bracket of the 30s, will drop them from here to here. Because here, as you can see, this is equivalent to this, and the same here, this is equivalent to this. So really, the combination of both is quite important. So the question now is about potassium. So are all salts that we take and eat on a daily basis bad? Well, apparently not. When you give potassium supplement for a person with hypertension, whether that is potassium chloride or potassium citrate, you see the blood pressure drops equally between the two forms of potassium supplements, and the urinary potassium increase with no statistical difference between the two types of potassium. So supplementing potassium is quite important. When you log in on the Harvard Medical School website and you find the information of potassium and blood pressure, it is clear. Their advice is the current American diet is too rich in sodium and too low in potassium. And reversing this imbalance would help to improve blood pressure and reduce cardiovascular heart attacks, strokes, and death. We've heard today so many presentations, and we'll hear more presentation about lots of studies and lots of drugs that are important for protection of the cardiovascular system. We have fantastic opportunity to help our patients without necessarily increasing the number of medication. So we need to think of potassium-rich food, because potassium can relax the muscles and relax the blood vessels and consequently reduces blood pressure. So in this particular study, they looked into systematic review and meta-analysis of 22 randomized controlled trials, including over 127,000 persons. And they were all reported for all the cardiovascular outcome. When they looked into increased potassium intake, that lowered the blood pressure in general by 3.4 millimeters mercury for systolic and by nearly 2 millimeters mercury for diastolic. But when they looked into those with high blood pressure, specifically having the higher potassium intake of the 90 to 120 millimoles per day, they had a much better reduction of systolic blood pressure. And importantly, that this increase in potassium had no adverse effect on renal function, on blood lipids, on catecholamines in adults. And they consequently saw an inverse statistical significance between the level of potassium intake and the cardiovascular outcome for many of the problems that we encounter. So, as I mentioned, it had no effect, no harmful effect, and also no beneficial effect for potassium supplementation for normotensives. But for hypertensive people, as you can see from the meta-analysis, it was quite helpful in improving blood pressure. So we've reviewed now the type of food that a person with hypertension should eat or drink, and we also reviewed what is the good salt and the bad salt, the maximum amounts, and the evidence of benefit of these. I would like to show you a demonstration of how this works from a randomized controlled trial that we did when I was working in my ex-hospital, and the study carried on after me moving here. Professor Mollhauser from Germany was the owner of the patient education program, which we modified to suit the British people. I have shared some of these slides before, but I'm just showing some of it for demonstration of what we did. So giving people structured education for hypertension, as well as home blood pressure monitoring in groups over 4 sessions, this had an impact on people. They understood this amount of salt they should take and how can they reduce it by clever choices in their food of every day. They also understood how can they lose weight of an average of 3 kilograms and what's the impact of such a weight loss. They also understood how can they cut down on alcohol intake and increase physical activity with its impact on their blood pressure. Salt advice was very important, and indeed they understood when they read the packet of the food, when they write sodium or write salt, what is the equivalent of this or that. So 1 gram of sodium is equivalent to 2.5 grams of salt. They also understood how to check blood pressure at home, and they were checking the blood pressure on a regular basis at home. The beauty of applying such simple methods of patient education as well as home blood pressure monitoring is we ended up after 12 weeks, 50% achieving blood pressure target, and after 24 weeks, 60% achieving that target. In the routine group who had the medication and the routine advice, that was not achieved except for 20%. But the beauty, such a high achievement of blood pressure target was achieved with only a 0.2 increment of antihypertensive versus 0.6 increment in the normal control, although they have not achieved the same level of blood pressure management. So one crucial point, we do not advise our patients to check blood pressure at home because of cost, although we give all our patients blood glucose monitors and strips, and sometimes we give them CGMs as well. Well, over 3 years, the cost of a blood pressure monitor, similar to the one I showed you here, and the cost is for both. This would cost 160 dirham over 3 years, and the blood glucose monitoring, if you buy it from a pharmacy, it will cost you 5,000 dirham over 3 years. The benefits of both is very important, but it seems that we advise on one and ignore the other. What's important that we also understand hidden salt. Many of the food that we eat every day is rich in salt, and that is something people with hypertension need to know. so that they can reduce the frequency or reduce the amount of both. We said that the recommended daily salt intake, sodium intake, is 1500. That is what is there in this Hungry Jack's cheeseburger. It looks nice, I have to admit, but if I have high blood pressure, this is something I need to think. And we haven't yet looked into the price that the person would have with the added salt on top of it. If you go for this ultimate double whopper, it is 1900 milligrams of salt. If you go to the Zinger Stacker burger, that's from KFC, that's 2,300 grams of salt, milligrams of salt. That's extremely high. In just one sandwich, you have 1.5 times the allocation on a daily basis. Well, in the Middle East, we love our salt, and we are amongst the highest globally on the daily salt consumption. And some of the salt is hidden. Any food that is preserved, it's preserved in fluid that contains high content of sodium. Cheese, salted nuts are obviously rich in salt. Of course, we love our pickles, mekhalil, our cheese, and our olives, and they are all pretty rich in salt. So what should we do? Should we stop eating these? No, we should go for the low sodium options. We have plenty of cheese that is low in sodium. We have plenty of types of olives that we can do without being salted. And indeed, we can have nuts that are not salted. If I have high blood pressure, I need to know what I eat and drink to improve things. Adding spice will make the food taste good, because spice does not increase the blood pressure. But this big meze meal of Lebanese, Syrian type of food, you will see on the table always the salt container, and some of them are rich in salt. But there are plenty of other options that are not rich in salt, and it's indeed very healthy, compatible with some of the points of the DASH diet or the Mediterranean diet. But remember also the food that is rich in potassium, the almonds, the avocados, the broccoli, the spinach, the mushroom, the beetroots, and all the tomatoes, of course, and the broccoli. All of these are very important food for a person with high blood pressure, as long as they have normal renal function and do not have hyperkalemia. So my conclusion is to remind you that antihypertensives are very good and they can lower the blood pressure, but salt reduction could be equivalent to some of the antihypertensive, and combining salt reduction with a DASH diet exceeds the ability of a single antihypertensive agent. So almost my last slide is the take-home message. Stop salt, stop excessive amount of salt, have plenty of fruits and vegetables, plenty of low-fat and low-carb food, exercise, and don't forget the potassium-rich food. And with this, I leave you with the photos of my beloved city, Alexandria. I hope you've got the message of something that is really quite important. We always discuss medicine, we always discuss drugs, we always discuss which class, when in reality, the difference between one and the other is sometimes marginal. And we ignore such an important topic that could save so many lives. I will here stop and hand over to Professor Juma Al-Kabi.
Many thanks, Dr. Mohammed Hassanein. Wonderful talk as ever, clear message, and many thanks of touching on something we tend to forget in hypertensive clinics. We focus on medication and we forget about something very, very essential and important, which is non-pharmacological approach, lifestyle approach in terms of the management of hypertension. And we're moving on to our third speaker. Our third speaker is the mastermind behind the series of webinars focusing on hypertension. It's Dr. Alauddin Bashir. He's a consultant endocrinologist at Dubai Hospital. He's the current president of the Sudanese Diabetes Association, Untitled Chapter. and he is a very active member of a research group, and he has published more than 70 original papers and review articles. Welcome, Dr. Alauddin, and he's going to focus on the prevalence of cardiovascular disease and hypertension.
Thank you very much, Dr. Jum'a, for this nice introduction. Today, my talk is actually very simple. It's basically preparation for Dr. Melanie Davis' talk, and I'm going to talk about the prevalence of cardiovascular disease in patients with diabetes. And to start the talk, I think we all know that patients with diabetes are at very high risk of cardiovascular disease. And in a 6-year-old male patient, those patients, they die 12 years earlier if they had cardiovascular disease and diabetes together. And they die almost 6 years earlier if they had diabetes alone. And the issue with that, behind that, is that diabetes is really very common problem. In the MENA region or in the Gulf region, there are many countries that are counted in the top 10 with the prevalence of diabetes in their population. And in US, almost 29 million patients has been diagnosed with diabetes. And that actually carries a very high cost for the economy. If you look at the burden of cardiovascular disease in those patients, it's #1 cause of morbidity and mortality. And as I said, it carries very high burden and cost on the economy, as it represents almost 49% of the total direct cost for management of diabetes. So I'm going to answer in this talk a couple of questions. Is it just diabetes that carries the high risk for cardiovascular disease, or there are other factors that increases the risk of cardiovascular disease? And if you look at this meta-analysis of 18 trials that looked at the risk of cardiovascular disease in patients with impaired fasting glucose and impaired glucose tolerance, those are patients who are not yet diabetic, but they are at high risk of developing diabetes. So if you look at this first graph, if you look at patients with impaired fasting glucose, these were the trials. And if you look at all the trials, actually there is an increased risk of cardiovascular disease in patients with impaired impaired fasting glucose. And if you look at the overall result of the meta-analysis, you can see that the risk of cardiovascular disease is significantly increased, and there is almost 18% increase in the risk of cardiovascular disease in patients with impaired fasting. Similar results you would see if you look at patients with impaired glucose tolerance. Patients with impaired glucose tolerance, almost 20% of them are at higher risk of developing cardiovascular disease compared to non-diabetic patients. And if you look at patients with metabolic syndrome and you look at the risk of death in patients with metabolic syndrome, we know that diabetes is part of the metabolic syndrome. And the risk of cardiovascular death or coronary heart disease actually increases significantly with the number of the components of the metabolic syndrome. So if the patient is obese, if the patient is diabetic, if the patient has high triglycerides, low HDL, or even high blood pressure, with each one of them, you get an increase in cardiovascular disease and an increase in coronary heart disease. So the more number of components of the metabolic syndrome, the higher the hazard ratios for mortality. And now, if you look at metabolic syndrome and diabetes, if you look at patients with no diabetes and no metabolic syndrome, the prevalence of coronary heart disease is around 8.7%. And it increases if they had only metabolic syndrome to 13.9%. And even higher if they had diabetes and metabolic syndrome together, it goes to up to 20%. So a patient with impaired fasting glucose, patients with impaired glucose tolerance and patients with metabolic syndrome are actually at very high risk of cardiovascular disease, and not only diabetic patients. And if we look at patients with diabetes, this is a very famous graph you see always, and this is from the East-West study. They looked at patients with a prior cardiovascular disease and patients with no prior coronary heart disease. And if you look at patients with no prior coronary heart disease, if they have diabetes, the risk of events is almost 20%, while if they had a prior cardiovascular disease, if they don't have diabetes, is almost 19%. And that's why we always say diabetes is a coronary heart disease risk equivalent. Now, the risk doubles if the patients had diabetes and previous cardiovascular events to almost 45 events per 100 person per year. And we know that with prevalence of cardiovascular disease in diabetic patients, the risk of death also increases. So this is the survival. This is a graph from the same study, the East-West study, that looked at the survival rates. So the green line is basically non-diabetic without prior myocardial infarction, and their survival is normal. And the more risk that they get if they had a coronary heart disease or diabetes, or they had a combination together. So the yellow line or the orange line is basically a diabetic with a prior cardiovascular, with a prior myocardial infarction. You can see that the survival will drop significantly as the years go. So having diabetes and a previous cardiovascular disease actually increases the risk significantly. And this is again represented in this chart, where you can see patients with diabetes and the risk of cardiovascular events and death. So if a patient is diabetic, the risk of cardiovascular events, whether coronary heart disease, non-fatal MI, or any type of stroke, whether hemorrhagic or ischemic stroke, almost doubles. So you look at the hazard ratios, almost 1.7, 1.8, and 2.27. So it's very, this group of patients with diabetes are basically very high risk for cardiovascular disease. So what should we do? I think the answer is we should control risk factors. And when I say risk factors, we should control diabetes, we should control blood pressure, and we should control as well the lipid profile. So what data do we have? If we look at blood pressure control, and this is data from the INVEST diabetes sub-study, where they looked at patients with diabetes and hypertensive at the same time, and they tried to look for the risk of cardiovascular events, whether patients, the mortality, and whether patients are controlled or not. So a diabetic patient who is controlled, who has a controlled blood pressure, and a diabetic patient who doesn't have and who has an uncontrolled blood pressure. So if you look at the green line represents patients with diabetes who had an uncontrolled blood pressure. And if you look at mortality, mortality is significantly high compared to patients who are well controlled. And if we look at the UK-BDS trial, this summarized the whole thing together, diabetes and tight blood pressure control. And it showed that if you have a controlled, tightly controlled glucose and tightly controlled blood pressure, you reduce fatal MI by 6% if you tightly control blood glucose, and 28% if you control the blood pressure. And the same for non-fatal myocardial infarction. However, when it comes to stroke, and we know this information, that patients with high blood pressure, they have higher risk for stroke, and control of blood pressure mainly controls the stroke and reduces the stroke risk. So if we have a tight blood pressure control, we reduce the fatal stroke by 58% and non-fatal stroke by almost 44%. However, both diabetes and hypertension control reduce the heart failure, but it's more for hypertension. So if I would like to control risk factors in a diabetic patients, I should focus on blood pressure control as well. What about agents used to control the blood pressure? This is a summary of many trials that looked at control of hypertension in diabetic patients using specific class, which is the ACE inhibitors. And you can see in many of the trials, using ACE inhibitors has significantly reduced the cardiovascular risk. So now I should control the blood pressure, and I should choose the right medicine to control the blood pressure. So use of ACE inhibitors and ARBs does reduce the risk of cardiovascular events. Now, what about the lipid profile and LDL control? Now, this is the heart prevention, heart protection study, which used statins to control the LDL levels. And if you look at patients, whether they're diabetic or not diabetic, they had significantly reduced cardiovascular events using the statins. There is almost 24% reduction in cardiovascular events. And this is a summary of, or a meta-analysis of 18,600 patients with diabetes in whom the statins has been used in different trials. And the meta-analysis has shown that using statin in reducing LDL in patients with diabetes does really improve the risk of cardiovascular disease. So the best thing we do is we control the blood pressure, we tightly control the blood sugar, and we address the lipid profile as well. And there is this STENO2 study that has looked at multiple intensive risk factor modification. So they tightly controlled blood pressure, lipid profile, and blood pressure. And you can see with intensive control, the primary endpoints were actually achieved in patients with conventional. So more events occurred in patients with conventional treatment and less with patients with intensive therapy. So it does actually answer the question of what should we do? We should intensively modify all risk factors. However, there is something important to look at. Even after intensification of all risk factors, what remains down here is the residual risk. So even after intensification of all these risk factors, there is a residual risk in diabetic patients. How should we handle that? I think we should look into, for example, new medications to treat diabetes, whether it will reduce the risk or not. And I think that's the focus of Professor Melanie Davis' talk. Now, how is the current control in our area? I would like to share with you two studies that look at the current control. We knew all this information, and we want to know whether we're achieving targets and we're doing very well. As with international data, the control of blood pressure or blood sugar or lipid profile is not really, people are not doing a very good job. And this is the data from Dubai Health Authority. This is a study that has been published in 2019 that looked at A1C control in patients attending the DHA facilities, whether primary healthcare or secondary level or even a tertiary level. And if you look over the years from 2012 to 2016, the best we achieved is 40% A1C less than 7%. Another almost 35 to 30% of patients fall in the area between 7 to 9% A1C, and a smaller percentage having an A1C above 9. So if we look at patients 40%, let's say average 40% below 70, and another 40% between 7 to 9% A1C, and more than that around 20% or 19% usually above 9. And the control in UAE nationals or non-UAE nationals is almost the same. There is no much difference, no significant difference between them. The total number of patients recruited in this trial were actually 25,000 patients. And the same study, we looked at high-risk patients with diabetes and whether we are doing well and controlling them well. If we look at the A1C in this group, a very small number of patients actually are achieving targets. So now I'm talking about a patient who is high risk for cardiovascular disease and renal disease and look at how many % of them are achieving actually a good glycemic target. Only 14 to 21% are achieving an A1C below 7.5. And another 22% around 7.5 to 8. And most of the patients, more than almost 60%, are above having an A1C above 8. What about the lipid profile, whether in type 1 or type 2? We're having actually around almost 60% of our patients are achieving target A1C. Actually, 45 to 60% are achieving target target lipid profile in this high-risk group. And this remains now only one question is, if we're not achieving a good glycemic control in patients with or lipid profile or even blood pressure in patients who are known to have high risk for diabetes and cardiovascular, high risk for cardiovascular disease and renal disease, what should be our next step? I think the next step should be addressing these risk factors by using modern medications, and we need to look into the cardiovascular outcome trials that will be addressed by Professor Melanie Davis. That was my last slide. Thank you very much, and back to Professor Juma Al-Kaabi.
Thank you so much, Dr. Alauddin Bashir, enlightening talk. And our next speaker, as mentioned, is Professor Melanie Davis. Welcome, Professor Melanie. I know since this COVID-19, probably you have not been to the UAE. It has our pleasure to have you in the past during our Congress meeting. Professor Melanie Davis, Professor of Diabetes Medicine at the University of Leicester, and Honorary Consultant Diabetologist at the University Hospitals at Leicester NHS Trust, Co-Director of Leicester Diabetes Centre, University Hospital of Leicester's NHS Trust, and she's a co-chair of the ASD-AD consensus report on type 2 diabetes mellitus management. And the talk will be covering cardiovascular clinical trials in diabetes. Welcome, Professor Melanie.
So thank you very much, and it's really lovely to see you. Is it possible for me to share my screen? That's great.
Sure.
I'll just get my slides up. Oh, I'll just go back to the beginning, sorry. Thank you. Can you see my slides now okay?
Probably coming on the way. Not yet.
Yeah, is that okay?
Not yet, no.
Okay, that's perfect. Thank you. So thank you very much, and thank you very much for the invitation this evening. It's a real pleasure to be at this meeting, and I apologize that I can't be there in person. Obviously, it's a strange time.
Professor Davis, we cannot see your slide.
You can't see my slides? No,
not yet.
Okay, I can see my slides. I wonder why you can't. Can you see them now?
Not yet. No.
Oh, how bizarre.
Probably there's, yep, they're coming up.
Yeah, you can see them now, yeah?
All of them.
Yeah, but you should just see, I'm going to go to the first one now. Is that okay?
All right, yes.
Apologies
Perfect.
for that.
That's good.
Apologies. Okay, so thank you very much for the invitation. I'll get straight into it. Sorry for the delay there. These are my disclosures. What I'd like to do, from following on from Dr. Bashir's very nice presentation, is really continue to make the case for a holistic approach in type 2 diabetes, but really put the cardiovascular outcome studies in context. So I think he very nicely described the excess risk in people with diabetes, and whilst over time we've made some impact on reducing complications, you can see that end-stage renal disease remains a significant problem, And I think one of the real worries is that there continues to be a gap in outcomes, both in death and death from cardiovascular disease in people with diabetes, with type 2 diabetes, compared to those without diabetes. We've looked at whether we can close that gap with controlling glucose levels, and this is in 2015 a meta-analysis of nearly 100,000 patients in studies both looking at regimes to lower glucose and with particular agents. And you can see that there was a very modest reduction in 3-point MACE, in MACE of around 5%, and an increase in heart failure and a very small reduction in the risk of MI. Now, we know that there's a link, a very close link between type 2 diabetes, cardiovascular disease and heart failure and chronic kidney disease, and that many patients have comorbidities which cross between these interrelated conditions. And we understand now that the cardiovascular, renal and metabolic systems are very interrelated, and that changes in one may have a positive or a negative impact on the other, such that if we, for example, energy metabolism is essential for the healthy function, particularly in the heart and kidneys, and that the kidneys play a key role in glucose and volume homeostasis. So these are very interlinked. And we're focusing now not just on glucose reduction, but on reducing mortality of patients and morbidity of patients. And diabetes and kidney failure are very interlinked. And you can see that diabetes in the US is the commonest cause of kidney failure. And that really chronic kidney disease has been very disappointing in terms of the potential intervention. So really in the last 15 years or so, there have been a number of different interventions that have been developed to try and target the kidney, and none of these have really led to game-changing benefits. Similarly, if we look at heart failure, we know that heart failure is one of the common first comorbidities in patients with type 2 diabetes, even compared to things such as MI or peripheral arterial disease. So, heart failure is increased in patients with diabetes, both in men and women. And I think this is an important study. This was published in the New England Journal of Medicine. And if you look across at excess mortality as you control different risk factors, you can see, for example, in panel B for MI, that if you control other risk factors, then your risk of acute MI is in people with diabetes is pretty minimalized. Similarly, in stroke, apart from in the very young age group under the age of 55. However, if you look in heart failure, even if you optimally control other risk factors, you can see that there's still an excess of heart failure, particularly in the younger age groups. And so we need to look at other interventions to reduce heart failure. As has been said, holistic approach in terms of blood pressure, and I think Mohammed's talk around the importance of education and dietary interventions are really well made. And we need to control blood pressure, LDL cholesterol, and obviously glycemic control. And obviously we shouldn't forget lifestyle interventions. So having said that, now I want to talk about the cardiovascular outcome trials. And I think it's important, and this is not all of the studies, but it picks out a few of the studies to look at the baseline characteristics in these patients that were recruited to the earlier trials. So this is EMPA-REG, CANVAS, LEADER, and SUSTAIN. And you can see actually there was pretty good control of cardiovascular risk factors with reasonable blood pressure, the majority of patients on antihypertensives and lipid lowering and antithrombotic, and an attempt to obviously also give people lifestyle advice. And so the data that I show you is pretty much on top of reasonable cardiovascular risk management. So I want to talk about these studies now. And since 2015, and it's really only been in the last 5 years that we've had the SGLT2 studies, and the DPP4 studies slightly earlier than that. But we've seen an absolute minefield of fantastic new data, which has completely revolutionized our potential to manage type 2 diabetes. So just a couple of slides on the DPP4 inhibitors, and sorry this slide has slipped, but you can see that when it comes to 3-point MACE in the 4 recent studies with DPP4 inhibitor, there's really cardiovascular safety, but no cardiovascular benefit. And indeed, if you look at the risk of heart failure, you can see some heterogeneity with some of the agents, particularly saxagliptin, increasing the risk of heart failure, alogliptin having a slight signal, but with sitagliptin and linagliptin, there was really no increased risk. More recent data with the Carolina study in this head-to-head study. So this is the only one of the cardiovascular outcome trials where there's an active head-to-head, this time with a DPP4 inhibitor, linagliptin, and an SU. There was no advantage of the DPP4 inhibitor over the sulfonylurea. And I think this is reassuring and important data in terms of the use of SUs, although you do see an advantage with the linagliptin in terms of hypoglycemia, particularly rates of severe hypoglycemia, which were relatively uncommon, but the the relative reduction was highly significant in terms of the DPP4 compared to the sulfonylurea. So moving to the incretins, I've talked about the incretin enhancers, the DPP4 inhibitors. I want to talk about GLP-1 more broadly now, because Dan Drucker has described GLP-1 as the conductor of the diabetes orchestra. We know about the data in terms of lowering glucose and lowering body weight, but there's an increasing recognition of the potential for cardiovascular benefit through potentially direct effects in terms of reducing blood pressure and lipids, but also I think importantly through effects around inflammation, and the role of inflammation is becoming increasingly important. Now, the GLP-1 class is highly heterogeneous. So we have the exendin-based molecules such as exenatide and lixisenatide. We have the acylated human GLP-1s, liraglutide and semaglutide. And then we have what we call the macromolecular molecules such as dulaglutide and albiglutide, which now are available and can be given weekly, although we don't use albiglutide now because it's not really been commercially taken forward. If you look at these agents, exenatide is available as a weekly or a twice daily in immediate release formulation. And we also now have these weekly GLP-1s, so dulaglutide, semaglutide, which are now available in clinical practice. Albiglutide, as I said, has really not been made available, although that wasn't because of safety issues or any other concerns. Now, when we look at these studies, there have now been 8 studies with GLP-1 receptor agonists, 7 of which have been fully disclosed in the literature. The Freedom study with the implantable exenatide has only been released in a press release. But if you look at this slide, which is a little bit of a busy slide, but it gives you a feel of how there are some differences in these studies. And when we come to look at the results, I suppose there's always 3 reasons why you might see differences. One is because of a difference in the agent themselves. The second is in the difference in the way that the study was conducted. And the third is potentially the difference of cohorts that have been included into trials. And you can see that Excel was by far the largest study with nearly 15,000 patients. And Pioneer 6 was one of the smallest studies with just over 3,000 patients. You can see in terms of the A1C inclusion, importantly, Rewind, which is with dulaglutide, had no lower limit of A1C. So patients could be recruited with A1Cs of 5.5 or even 6%. And you can see that the inclusion criteria for the background cardiovascular risk is very different. So, for example, in LEADER, the majority of patients had established cardiovascular disease, whereas in Rewind, there was a significant number of the cohort who had only risk factors only. If we look at the endpoints, you can see, and the follow-up, you can see that there were some differences. So Pioneer 6 was a small, short study of only 16 months, whereas Rewind went on for over 5 years. You can also see that the majority of the studies looked at 3-point MACE, apart from Elixir, which was 4-point MACE. And as I've said, in Rewind, there was a much lower percentage that has had established disease, only around 30%, whereas 70% had subclinical risk factors. Whereas in Elixir, for example, virtually all of the patients had established disease. Now, this shows you the overview of the outcome studies, and you can see, if you look at the top level, there is quite heterogeneity in the primary outcome. So we have 4 studies that were significantly positive for MACE, which was LEADER, SUSTAIN 6, Harmony, and Rewind. And we have 4 studies which didn't reach statistical significance. Elixir, where the hazard ratio was pretty much 1. Excel, which was 0.94. Pioneer, which was 0.79. But as we've said, this was a smaller, probably underpowered study. If we look at the number of events, this tells you, if you look at the events, for example, in the placebo arm, you can tell the risk of the patient. So, for example, if you look at the background level in Rewind, only 2.66, this is a much lower risk population compared, for example, to in Elixir, where the rate of MACE events per 100 person years was nearly 3 times that, over 6. So that gives you a feel of the different risk profile in these patients. If we look at death from cardiovascular disease, the only study that showed a statistical significant lower result was LEADER. There was a suggestion of a reduction in Pioneer 6, in fact, the hazard ratio 0.49, but again, this study was underpowered. Well, it wasn't appropriate to report the p-value for this exploratory endpoint. And if we look at heart failure, you can see that when it comes to the GLP-1s, they don't appear to show an increase in the risk of heart failure, but neither is there any reduction. So this slide just summarizes these results. So there is heterogeneity across the class, but a number of the agents show a significant reduction in 3-point MACE, no effect on hospitalization for heart failure. And as you say, if you look at the individual MACE endpoints, you see some difference with SUSTAIN, for example, showing a reduction in non-fatal stroke, and Harmony showing a reduction in non-fatal MI. Now, as I've said, really there is no signal at all of any benefit from heart failure, and there doesn't appear to be any benefit, any signal for harm, however. Now, if we look at the kidney, and I think this is important to look at the kidney endpoints in these studies, this is from LEADER and SUSTAIN. And in both these studies, there was a significant reduction in the composite renal endpoint, which was defined as new onset persistent macroalbuminuria, doubling of serum creatinine, renal replacement therapy, or death. Now, that sounds a good thing, and of course it is. but it was largely driven in both with liraglutide and semaglutide by a reduction in albuminuria. And if you look at these harder endpoints, we didn't see an impact on those, which is in contrast to the SGLT2s, which I'll come to in a minute. So that's the GLP-1s, I think a fairly robust signal in terms of MACE, both people with and without risk factors, because we've seen the data in Rewind. No harm, but no benefit on heart failure, and a reduction in renal endpoint, but largely driven by a reduction in proteinuria. Now, what about the SGLT2s? And there are now 6 studies, because remember, Canvas was 2 trials. There's EMPA-REG, DECLARE, CREDENCE, and also pretty hot off the press, the VERTIS cardiovascular outcome study. So with EMPA, we've got EMPA-REG, canagliflozin with Canvas, dapagliflozin with DECLARE, and also canagliflozin with CREDENCE and ertagliflozin. Now, as I showed you with the GLP-1 studies, there are some differences in these studies. So by far, the largest trial was DECLARE. And also, as you know, that had a significant proportion of patients with only multiple risk factors. So if you look at the history of heart failure, for example, the highest proportion was in VERTIS CV at baseline. The lowest proportion was in DECLARE and EMPA-REG. If you look at the mean A1C, there was really quite marked similarity in the A1C at baseline. If we look at EGFR, apart from CREDENCE, which we'll come back to, most of these studies were pretty similar in EGFR between 75 to 85. So not much difference in the renal function at baseline. The majority of studies, apart from CREDENCE, and the majority of patients, even in the CREDENCE study, were on a background of metformin. And if you look at the MACE per 100 patient years, you can see it was lowest in DECLARE, as you would expect, at 1.5, and highest in CREDENCE. And I would suspect that VERTIS and EMPA-REG would be pretty similar in their background rates. So this was the data pretty much up until recently, where this reduction in 3-point MACE was seen in EMPA-REG and Canvas, but not in the DECLARE study. The reduction in cardiovascular death was only seen in the EMPA-REG study. But for secondary endpoints, we saw this reduction in hospitalization with heart failure, and also this reduction in the composite of cardiovascular death or hospitalization with heart failure. Now, if we look at VERTIS, so this is a VERTIS study that was presented just the day before yesterday. This is the primary endpoint. So remember, these patients were high risk, very similar in some ways to the EMPA-REG study, quite a large trial. And the study didn't reach its primary endpoint for MACE for superiority. It met it for non-inferiority. So it's safe, but the hazard ratio at 0.97 is clearly not superior. If you look at the, so the co-primary endpoints were MACE, which I've said to you was non-inferior, but also this composite of cardiovascular death and hospitalization for heart failure, which is similar to the DECLARE study in a higher risk group. But again, but in contrast to DECLARE, this study did not reach statistical significance, and neither, because of the hierarchical testing, then it's not appropriate to go on and look at the p-values in much detail for heart failure and cardiovascular death and renal composite, but we all do. And there was no reduction in cardiovascular death. And I'm going to come back to the heart failure and renal composite later. So this is a updated meta-analysis now, including VERTIS for MACE. And you can see that across the class, the pooled estimate is 0.89. And you can see the Vertis is sitting at 0.99 and not significant on its own. The issue is in patients with no established cardiovascular disease, apart from in credence, we don't really see an impact of the SGLT2s on MACE endpoints. If we look at patients in terms of time to cardiovascular death, there does, as I've said, there is a reduction in cardiovascular death across the class. But if you look at the factor for heterogeneity at 64%, there's a reasonable amount of heterogeneity across the studies. And this is really driven mostly by the EMPA-REG result, with all the other studies not really showing significance. If we look at this in the round, you can see EMPA-REG at the top with the reduction in MACE, cardiovascular death and heart failure. Below that becomes the CANVAS program with a reduction in MACE and heart failure. Then we see DECLARE, obviously a much higher risk of patients with risk factors in this cohort. And then at the Vertis at the bottom, which was, as I said, quite more similar to EMPA-REG in terms of the baseline characteristics. So this is interesting, and I'm sure will be hotly debated. So as I've said, if you look at the impact on SGLT2s on MACE, there's some evidence that we do get an impact in people with established atherosclerotic cardiovascular disease, but really not much evidence of impact in patients with multiple risk factors. Now, coming on to the kidney, this was a secondary endpoint in EMPA-REG. There was this stunning result at the time, which I think was really a really important finding and continues to be this impact of the SGLT2s on the kidney is such an important implication for our patients. And unlike the data with the GLP-1s, this wasn't just driven by a reduction in proteinuria. It was also significant for hard endpoints such as doubling of serum creatinine, which was almost halved, a 55% reduction in initiation of renal replacement therapy, and a more than halving of this very hard renal endpoint of doubling of serum creatinine, initiation of renal replacement therapy, or death due to renal disease. And so when we look at the impact of SGLT2s on renal endpoints, we see it in people with established atherosclerotic cardiovascular disease, but also in patients just with multiple risk factors. And this is a really important finding. Now, if you look at the Vertis data, and you have to report the data that you defined, their definition for the composite endpoint was a doubling of serum creatinine, dialysis, transplantation, or renal death. And although it was in the right direction, it did not reach statistical significance. And really, we shouldn't be so much looking at it because it was, as I said, once you'd failed to get the two primary endpoints, we really shouldn't be looking at these endpoints, but it's sort of in the right direction. But if you look, as was presented by David Cherney, and look at exactly the same definition across all of the studies, then you see much more similarity. Now, you can argue that, if you set your study up and you define your endpoints as you do, then you really shouldn't look at this. But I think it gives us some confidence in the class that there does seem to be a robust impact on kidney function. Just looking at credence, because this was an important study, because the primary endpoint was a renal endpoint in this study, and it was reached a 30% reduction in this primary endpoint of end-stage renal disease, doubling of serum creatinine, renal cardiovascular death. Very robust data, again, on these individual indicators of the composite, all going in the right direction. And also showing a reduction in cardiovascular death in this cohort. There was a concern around the amputations, which was seen in the CANVAS program, but in this high-risk group, where there was obviously some additional surveillance of foot complications, we didn't see an increase in amputation. So if we look at the SGLT2s in reducing renal disease, we've got really pretty robust evidence now. This doesn't include the VERTIS data, but we see a 33% reduction in dialysis transplantational death, a 35% reduction in end-stage kidney disease, and a 25% reduction in acute kidney injury. So this is really very important. Now, what about heart failure? Again, in the EMPA study and in the real world data, we saw this reduction in heart failure. And remember, in the EMPA reg study, this was a secondary endpoint. Now, if we look across glucose lowering classes, if you start at the bottom, you can see the TZDs, which increase your risk of heart failure. We move up to the DPP4 inhibitors, where there's heterogeneity, with some agents increasing heart failures and others being neutral. We have the alpha glucosidase inhibitors, insulin, and the GLP-1s, which are pretty neutral. And then we come up to the SGLT2s, which show a benefit. And this shows the reduction to time to first hospitalization with heart failure, now including the VERTIS study, where there was a 30% reduction in heart failure, although, as I said, it was below the hierarchical testing, but it's included here. And it shows, if you look now at heterogeneity, remember when I showed you cardiovascular death, it was around 65%, so quite marked heterogeneity across the studies. Here, it's 0. So there appears to be a very robust signal for SGLT2s in heart failure. If we look at data from DECLARE, and indeed there was some data presented from VERTIS as well, that this appears to be particularly of benefit in patients with reduced ejection fraction heart failure. This has further been shown in the DAPA heart failure study, in which patients with and without type 2 diabetes, but with reduced ejection fraction heart failure, were randomized to either dapagliflozin or standard of care. So this shows the design of the study, nearly 4,500 patients, more than 4,500 patients. And this shows you the primary composite endpoint of cardiovascular death, heart failure hospitalization, or urgent heart failure visit, showing a significant reduction with dapagliflozin, with a number needed to treat of only 21, a reduction in cardiovascular death, and the endpoint being similar in people with or without diabetes. So this will support a licensed indication for dapagliflozin for heart failure, even in people without diabetes. And we're seeing very similar data, which has been presented from the EMPEROR reduced study with empagliflozin. We now know that there are many mechanisms which link and appear to be associated with why SGLT2s may confer significant benefit both in heart failure and kidney disease. So in summary, type 2 diabetes is associated with increased cardiorenal morbidity and mortality. The cardiovascular outcome trials reveal differences both between but within class in terms of cardiorenal protection. Thank you very much for your attention.
Many thanks, Professor Melanie, for rather well-illustrated talk regarding number of medication, different classes, and their outcome as clinical trials in the patients with diabetes. Thank you so much. And we're coming now to the Q&A sessions. Before that, I'm glad to say that we are approaching over 600 attendees for this activity. And this webinar is accredited as 1.5 CME hours from the Ministry of Health and Prevention. And we'd like to start with the questions and comments. So let's start with the first one. The first one is a comment by Professor Janusz Jakonowski from the UK. He mentioned here, I was a clinician overseeing the NICE hypertension guidelines published last year, I accept that the blood pressure treatment levels were higher than some would have liked. Thank you, Professor Janusz. The second question is from Dr. Mahmoud Ashraf Ibrahim. If you're given the choice between ACE versus herbs in diabetic patient, which one are you going to use? Do we have the mics for all the speakers?
Yeah, I think there's no real difference in the data between ACEs and ARBs. I think you can use either. It's just contraindication of ACE is cough or others.
Okay, so there's no solid data to favor one or other, but if there's intolerance to herbs, then you switch to intolerance usually to ACE, you switch to herbs.
Well, I think this is the policy that many people do. They start with an ACE and if intolerant go to herb, but there is, from a scientific, maybe this is cost related, but from a scientific point of view, the guidelines across the globe are saying A as a class is to be initiated for people with diabetes and without differentiation between ACE or herb.
Okay, that's clear. And a question for Muhammad. Now there is in the advertisement, they tend to advertise zero sodium water. What do you comment on that?
Well, it's not just about one single item. I think we need to be conscious about the salt that we have specifically in food. We have the habit of adding salt when we cook, and then we add again salt when we are eating. I'm one, I used to do this, and my wife used to shout at me and say, taste it first. So I stopped doing this, and I tasted first, and I got used to a lower level of salt compared to what I used to in the past. So we get used to what we do. But for some, they enjoy excessive amount of salt. Well, if they have hypertension or indeed heart failure, that's something that would be harmful for them. So we need to look into the collective salt intake across the day, specifically the hidden salt in many of the food choices that we have.
Okay, thank you. But in terms of advertising for zero water, zero sodium water, what's your take on that?
I honestly don't know whether it's of any extra benefit or not. Water is not one of the sources of rich sodium, but maybe for some it would be good. I don't know.
Okay. Another question from Dr. Mahmoud Ashraf Ibrahim. Can GLP-1 be given to type 1 diabetic patients?
No, so there's no license for GLP-1 in people with type 1. There were some studies done a few years ago, and part of the issue was that there was an increased risk of hypoglycemia. So as you know, SGLT2s have been developed for patients with type 1, and indeed in Europe now, DAPA and sotagliflozin have a license in type 1 diabetes, and in some of the kidney outcome studies, for example, EMPA-Kidney, they're including people with type 1 diabetes. So the SGLT2s may have a role, but thus far, the GLP-1s, although it sounded a reasonably good idea, the adjunct studies didn't really support that, were associated with an increased risk of hypos, and there's no license or phase 3 program being pursued to look at GLP-1s in type 1.
Thank you, Professor Davis. That's clear. And the question from Dr. Keisha Al-Sibi. And the question is, what is your view about pink salt? I never heard about pink salt.
About what?
Have you heard about it?
About what, sorry, Dr. Juma?
Pink, just like the color pink.
Pink salt.
Yeah.
I don't know if color matters. I'm not sure if any of the colleagues know more about. There was an earlier question which I answered about in writing about Himalayan salt. So yes. I don't know what is a Himalayan salt and what's a pink salt. Anyone knows?
No idea. We've never heard about it.
Himalayan, it is available in the market. They say it is more of natural type of salt, and it is better than the sea salt.
Well, I think we need to be fair, to look into the label of these things, to look into the content of sodium in them, and be able to calculate accurately what is the total salt and sodium intake. So we obviously say we need to cut down, but how much you cut is based on the sodium content in that type of salt.
Right, we'll move on to the other question by Dr. Raya Ahmed. And the question, patients with A1C 13 and asymptomatic, what could be done for them? That's more of management of severely uncontrolled diabetic patients.
The guidelines recommend for such high patients to start on insulin, and then maybe in the future that could be reconsidered. If they are seriously resistant to this, I guess sometimes the combination of GLP-1 with insulin could be of benefit. But with HbA1c of 13, you wonder that the person is seriously insulin depleted and they probably should go on intensive insulin therapy. That's what's also in the guidelines where they said HbA1c above 10, you need to go for insulin therapy.
Yes.
So I would broadly agree with that. I do think, though, that we probably need to know a bit more information, because increasingly we are seeing people with type 2 diabetes don't have a huge amount of symptoms, who are very overweight, who are presenting with quite high A1Cs. I've had a couple of patients in the last couple of months with A1Cs over 12, who actually now are on a combination of insulin and GLP-1 or others and have done quite well. I think if that patient had a high BMI and was asymptomatic, I agree we need to just check that we're not missing type 1 and make sure that we get them controlled. But some of those patients would need, particularly if they're very obese, would need massive doses of insulin. So sometimes it's good to keep an eye and see whether combination would be useful in those patients.
Right. And a question from Dr. Raya Al-Mazroui. Any study regarding combination of GLP-1 and SGLT2 inhibitors on cardiovascular outcome?
So that's a great question. And, so at the moment, no, because as you know, most of the studies, particularly with GLP-1s and SGLT2s, there weren't many patients on the other background. So there's some data from the Excel study with patients on a background of SGLT2. And in some of the, obviously in clinical practice now, that combination is being used reasonably well. The reason it's a really good question is, of course, from a mechanistic point of view, if you've got the GLP-1s, which you think are targeting more inflammation and atherosclerotic cardiovascular disease, and the SGLT2s, which are targeting more potentially hemodynamic effects and heart failure and chronic kidney disease. And there's no reason why you, in the phase 3 studies and their license, you can use them together. It would be really interesting to see what the long-term cardiovascular benefits are. But at the moment, there aren't studies looking at that, although some of the outcome studies, for example, there's a study called SELECT in obesity with the GLP-1, where, it may be that patients who come into that with diabetes may be on a background of SGLT2. So we might get some of that data in the future.
Thank you. If you recall, Professor Jum'a, that in our Emirates guidelines that we published earlier this year, we said that in those with high risk, the cardiovascular and renal patients, if they start on one and they are later poorly controlled, to give them the benefit of the doubt if resources permit to combine between both. We were aware that the evidence is not strong, but we felt that anyone going to add another agent if they're not well controlled. So you might as well consider one with some evidence. Of course, we would love to see the robust evidence of the combination.
Yeah, and that concurs very much with the ADA EASD. So if you start on a GLP-1, but you're not reaching A1C target and you have to choose another agent, then it would make sense to use use the other one. So I think that's a very pragmatic and sensible approach, because otherwise, what else are you going to be adding in people at high risk? You might be adding agents that are not likely to reduce their risk.
Right. And thank you. We have a comment here from Professor Yusuf Abdurazak regarding pink salt, which is the pink Himalayan salt. The same as table salt you mentioned here, it has 98% sodium chloride. The rest are a small amount of magnesium, potassium, and calcium. And it is extracted from a place in Punjab.
So pink and Himalayan are both more or less, it looks like it's the same thing.
Yeah.
Okay.
Right. When you start a patient on hypertensive medication, when you going to consider stopping it?
Say again.
Yeah.
What's the question
Question
again?
is, what is the low level of blood pressure to stop antihypertensive drug?
To stop antihypertensive drugs?
Yeah. If you start a patient on an antihypertensive drug, at what level you would consider or even reducing the dose or stopping the medication altogether?
Okay. So this is an interesting phenomenon. It occurs rarely. I've only seen it in the context of two things: sleep apnea being treated properly or bariatric surgery, right? So it's unlikely that a patient who has the properly diagnosed hypertension, usually it's an error in the diagnosis. You know, some people just get one blood pressure reading in the clinic, and we know the guidelines don't support that, and they're started on treatment, and then they become hypotensive. So the first thing would be if they have an erroneous diagnosis. So they are given antihypertensive and suddenly they become normotensive and symptomatic. So then you should question the initial diagnosis. And here a 24-hour blood pressure monitor is very helpful. Secondly, if they have a secondary cause, and we've had some patients with severe sleep apnea become completely normotensive, believe it or not. This is a very important phenomenon not to forget. And thirdly, people who lose a lot of weight either through bariatric surgery or GLP-1 and dietary interventions, they can become normotensive and in fact reverse their insulin resistance. In those patients, we generally would say if your blood pressure is in the normal range, solid normal, that's 120 over 80, that patient, you can down titrate the ACE inhibitor or ARB, make them check their blood pressure at home multiple times, and then see. Because if you've reversed the metabolic syndrome, you don't really have the reason for the hypertension. But this is not common. I mean, we know this is not a common phenomenon.
Right. A question from Dr. Iman Dana. Would you recommend to do periodic cardiac exam in a patient without diabetes but has hypertension and dyslipidemia?
I didn't catch the first part of that question.
Periodic cardiac examination. Refer to cardiologist to do a full cardio evaluation for a patient with hypertension and dyslipidemia and diabetes as well.
So evaluation with target organ damage is generally recommended, and it's limited to certain things. So generally, an annual ECG would be very reasonable to pick up abnormalities. Clinical questionnaires are very important. We have to ask patients, we have to get into the habit of asking patients if they have a functional limitation. So if a patient cannot go up 2 flights of stairs, right? So cannot go up 2 flights of stairs means they are New York Heart Association functional class 2. That's not normal, right? Why is that? So we have to start thinking. So a truly asymptomatic patient can go up 2 flights of stairs with no issues. So we can't say they're asymptomatic unless we ask, right? And then the other things, of course, looking at the retina, looking at the feet. I mean, I've learned this from my endocrinology colleagues a lot, that looking at the urine albumin creatinine ratio is a marker of cardiovascular risk, not just a marker of renal disease. So I've learned this, and it's in my practice now that I do this quite routinely in my high-risk patients, whether they're pre-diabetic or hypertensive. So as we do routine lipid examinations and A1Cs, I think it is important to at least once a year do an ECG, do a proper examination, physical examination, and get a good history. Now, the ESC guideline, I didn't have a chance to show you these slides, but the ESC guideline suggests in patients who have symptoms, even if they have mild symptoms and an abnormal ECG, if they have symptoms of dyspnea with an abnormal ECG and they're high-risk patients, an NT-proBNP can be used. And if the cutoff point is met, it's higher than the cutoff point, then referral to a cardiologist for an echo to look for cardiac structural changes like diastolic dysfunction, left ventricular hypertrophy, or left atrial enlargement. And this is supported by 2 studies, the STOP-HF and Pontiac studies, which looked at high-risk diabetic patients who did not have heart failure or cardiovascular disease. Since heart failure is becoming a really big endpoint in our diabetic patients, I think these kind of investigations are cost-effective and timely.
And Hani, you would like to know that from the data we collected, and we're in the process of publishing it from our hospital here, that the rate of admissions to the cardiovascular ward in people with diabetes who have heart failure was double the non-diabetics.
I'm not surprised. This is the missed complication of diabetes. We're so focused on atherosclerosis and renal, we're completely missing the heart failure outcome. You're 100% right. This is a brilliant data. I think really we should all have it.
There was one published paper looking at the myocardial infarction and stroke in the UAE population, and our population is tend to be 10 years younger than the Western population. I mean,
that's right. That's right.
Right. There's a question by Dr. Asma Mustafa. Do you encourage intensive control of hypertension and diabetes in elderly patients?
So this is I'll leave that to Dr. Malik.
Well, I was just going to make a very short comment to say it's not age per se, it's the sort of comorbidity and the overall health of that person. So you have some very frail people in their 60s, and you have some very good patients in their 80s. So I think it's important to look at the whole patient and not just their age alone.
Any further comments?
No, I entirely agree with this. Age is not the issue. It's I suppose the person asking means by elderly is the frail person. So in the frail person, whether because of age or because of illness, we need to be more careful. We need to look into postural hypotension, specifically if their hypoglycemia risk is high as well. We don't want them to wake up in the middle of the night with a hypo or postural hypertension, fall, break their hip, or have a subdural hematoma. So we need to think of the benefit of such aggressive approach, as we don't go for aggressive glycemic control for some. We also should not go for aggressive hypertension control for some, unless there is no harm. So the assessment of the postural hypertension and the other functions, the neuropathy, the postural issues, as well as the risk of hypoglycemia in such a complex patient is really important.
Thank you, that's clear. Another question by Dr. Iman Dana. In patient with type 1 diabetes, would you use SGLT2 inhibitor in congestion with insulin, and especially naive patients who under risk of hypoglycemia?
So I don't think there's so the evidence that has come with the SGLT2s is mainly in patients with established disease. So I certainly don't think we should be using SGLT2s at diagnosis. And the real benefit seems to be, there seems to be a reduction in blood pressure, reduction in weight, a modest reduction in A1C, and actually, if anything, a reduction in hypoglycemia, but with obviously an increase in ketoacidosis. And I think we have to weigh up the risk benefit. And there are now guidelines in terms of looking at where the A1C is, looking at the BMI, and looking at the blood pressure. So if you've got a person with type 1 diabetes whose A1C is over 8%, they're a little bit hypertensive, they're overweight, and they're otherwise stable, and they will ketone test, and they understand how to avoid ketoacidosis, because it's often euglycemic ketoacidosis, then that's where we should be using SGLT2s with, and we should use it in specialist settings with really motivated and well-educated patients. I don't think starting it in newly diagnosed, that's not been looked at, and we do have this little bit of a concern around the DKA risk.
Yeah. glycemic decay is common in this. Do you think the use of beta blockers in this part of the world is common in hypertensive patients?
It's difficult to judge Dr. Juma categorically, because obviously we see patients in the governmental sector where we are following guidelines, but there are many people who are in the private sector and maybe with restricted resources who go for the cheapest option. And maybe the beta blocker for them is a good option. It depends also on which which hypertensive agent you're thinking, selective or non-selective. But Hani maybe can, as a cardiologist, can shed some light on this.
So the use of beta blockers is mentioned in the current ESC guidelines. It's a little bit different than last time. If patients have evidence of sympathetic overdrive. So this is kind of a unique syndrome. And we have some young hypertensive patients that you notice are a little bit tachycardic, right? So these ones who complain of palpitations, they're often the obese patients who have RAAS activation, insulin resistance, sleep apnea. So it seems that the use of highly selective beta blockers, and I'm not talking about atenolol, right? Because atenolol is where beta blockers got a bad name in hypertension. Highly selective beta blockers that have less peripheral side effects may be useful to attenuate the epinephrine drive in some of these patients. So it's
a question from Dr. Humaid Sadiq. There are two components of the question. I'll start with the second part, which is, can we use GLP-1 in patients who are hypertensive, dyslipidemic, and pre-diabetic?
So at the moment, the only GLP-1 that's licensed for weight management. So if that patient was overweight with a BMI of over 30 or a BMI of over 27 with a comorbidity, we've got data from the SCALE study, obesity study with liraglutide at the 3 milligram dose, which showed benefits in terms of weight management and also benefits in terms of improvements, for example, in pre-diabetes, so more likely to revert back to normal glucose tolerance, and benefits in blood pressure. Right. There is, I presented it today, actually, there's the EASD, there's a program with semaglutide, which is looking at the 2.4 milligram once weekly dose of semaglutide in those group of patients as well, obesity. And the data, the top line data looks really pretty impressive. So you're getting 15 to 16% weight loss in those patients. So for weight management, yes, and there is a cardiovascular outcome study looking in that group. But if the patient wasn't overweight and didn't fulfill that criteria, at the moment the drugs are not licensed in that group.
Thank you. And I'm taking the last part of the question, and probably will be the last question as well. So probably you already touched on this. How effective GLP-1 in somehow the screen moved up. Okay. So a patient with type 1 diabetes who has established cardiovascular disease or atherosclerotic disease, how effective is GLP-1 in this group of patients?
Well, we don't know because we haven't done the studies. I mean, people with type 1 diabetes, it's a shame because we don't have good cardiovascular outcome interventions. We've had the removal trial with metformin, which was a little disappointing. We will get some data, I think, with the SGLT2s through the kidney and heart failure, particularly the kidney studies. But, we don't know whether GLP-1s would have a role, and the studies are not planned. And at the moment, there's no plan to license GLP-1s in type 1 diabetes. But, perhaps we should be doing that study.
At the end, I would like to thank our wonderful speakers, Dr. Hani, Dr. Mohammed Hassanin, and Dr. Alauddin Bashir, and Professor Davis. Thank you so much. It's been wonderful discussions and wonderful talks and presentations. We have learned a lot tonight. Thank you so much.
Thank you very much. Bye-bye to everybody. Hi, Mohammed. Bye-bye.
Thank you. And we are moving now to the last part, which is the talk by the sponsor of the event. The sponsor is Bringer. Their speaker is Dr. Ghada Awada, and the talk will be focusing on SGLT2 updates from type 2 diabetes to heart failure. Welcome, Dr. Ghada, and thank you for sponsoring the webinar. Thank you so much.
Thank you so much, Dr. Juma. Can you hear me?
Yes.
Yes, I will share my screen now.
But could you get closer to the mic?
Okay. Is this better?
Yes. Yeah.
Okay, thank you very much. Well, it would be simple and easy because Professor Melanie, thankfully made it very simple for us. What we will present today is the Emperor reduced, as Dr. Melanie discussed all of the cardiovascular outcome trials in the SGLT2s and also the DAPA heart failure. The long-awaited Emperor reduced was out in the Emirates Cardiac Society last month, and we will discuss its results and its details today. The Emperor reduced is a phase 3 randomized placebo double-blind controlled trial, and it's aimed to investigate the efficacy of EMPA on top of standard of care versus the placebo with heart failure patients in reduced ejection fraction. So mostly the population was diabetic and non-diabetic patients, 18 years and above, with a chronic heart failure with the New York Heart Association class 2 to 4. They were randomized between empagliflozin 10 versus placebo on top of standard of care, a total of 3,730 patients with reduced ejection fraction of less than 40%. The endpoints were the composite primary endpoint of the first adjudicated cardiovascular death or adjudicated hospitalization due to heart failure, and the secondary endpoints were the first and recurrent adjudicated heart failure events with the change of the eGFR slope and the change from the baseline. The trial inclusion is the patients with reduced ejection fraction based on the ejection fraction and the NT-proBNP patients, 18 years and above, and the heart failure class association from 2 to 4. Exclusion criteria were the regular exclusion criteria for the patients where there is a heart transplant, acute decompensated heart failure, or high blood pressure for the patients, and the eGFR was with less than 20 milliliter per minute. Baseline characteristics, not to go into too much details, the age was around 67, and they were equal with from the race and the region, and the majority of the patients were heart failure class 2 and 3 also, with a 0.5% of class 4. Their heart rate was stabilized, the heart blood pressure was stabilized, and the NT-proBNP, the average was 1,887 for the EMPA arm, compared to 1,926 for the placebo arm. And there was a history of hospitalization due to heart failure with 31% of the patients, and 50% of the patients were diabetic, the other 50% were non-diabetic, with an eGFR average of 61 milliliter per minute. The heart failure medication was the golden standard, and as per the guidelines, with ACE, ARBs, ARNIs, which is the sacubitril valsartan, and the mineralocorticoid antagonists with beta blockers. And 31% were on an ICD, 11% were on a CRT. Moving to the results, with the specific endpoints for the hierarchical testing, for non-inferiority and then for superiority, the primary endpoint was adjudicated cardiovascular death or hospitalization due to heart failure. The secondary endpoint was the first and recurrent heart failure hospitalization, and the third endpoint was the eGFR slope in the change of the baseline. For the primary endpoint, there was a significant 25% relative risk reduction for the empagliflozin versus the placebo on top of standard of care, with a p-value of less than 0.01. Translated to the absolute relative risk reduction is a 5.2% for the EMPA versus the placebo. And if we want to translate it to the number needed to treat, there is only the need to treat of 19 patients to save one life with the empagliflozin in the Emperor reduced trial. The key secondary endpoint, which is the adjudicated total hospitalizations for heart failure, whether first or recurrent, also we had a 30% relative risk reduction for the empagliflozin versus the placebo on top of standard of care, with a significant p-value of 0.001 also. Moving to the kidney and the change of the eGFR from baseline, and this is very interesting, especially for the heart failure patients. If we see here, as expected in the beginning of the first 4 weeks, there was a little dip of the eGFR with the patients, and then stabilization of the eGFR throughout the whole trial period with EMPA, and 30 days after withdrawal of the end of the study, the eGFR, there was a plus 3.3 milliliter per minute in the favor of empagliflozin versus a placebo, and this was significant. Unlike the placebo, where was a continuous deterioration for those patients throughout the whole trial period. So again, empagliflozin here proves that there is a stabilization and renal protection for the patients, also with the heart failure patients, regardless of diabetes. The eGFR slope, there was a 1.73 additional value for empagliflozin versus the placebo, with the eGFR slope difference per year significant with a 0.01 p-value, sorry. So the long-term renal function is preserved for the heart failure patients regardless of diabetes with empagliflozin versus the placebo. So summarizing the results, the primary endpoint was a 25% relative risk reduction, significant for cardiovascular death and hospitalization or hospitalization due to heart failure. The first and recurrent hospitalization for heart failure was a 30% significant for the EMPA versus placebo. The key secondary endpoint was a slope difference of 1.73 milliliter per minute per year, significant for the change in slope for the empagliflozin versus the placebo. And EMPEROR reduced is the first trial that proved for heart failure patients to have this conversion of the eGFR slope and the reduction and of the deterioration of the renal patients. So all of the 3 endpoints were met with a significant result with the EMPEROR reduced. The exploratory endpoints, which is the renal endpoint of end-stage kidney disease or sustained profound decrease in the eGFR, also there was a 50% relative risk reduction of empagliflozin versus placebo, significantly translated to 1.5% absolute relative risk reduction for those patients to sustain the profound decrease in the eGFR and end-stage kidney disease. If we wanted to talk about the primary endpoint of the first hospitalization or cardiovascular death, we see that the first hospitalization for heart failure is a 29% relative risk reduction significant. The cardiovascular death was an 8% relative risk reduction, just missed significance. But here is a confirmatory exploratory endpoint, and the cardiovascular death is well known from the EMPA-REG outcome trial with a 38% relative risk reduction. If we combine those two in the composite primary endpoint, we have the 25% relative risk reduction significant. So cardiovascular death here was not meant to be studied alone as a confirmatory endpoint. It was only exploratory, and there were no further studies on it to see if the significance will be done if we had a longer trial period, if you want to say, or more patients, because the EMPA-REG outcome confirmed a 38%, and we have an indication and there is a change in the guidelines. The quality of life, this QCCQ score was also 1.7 absolute difference in favor of empagliflozin versus the placebo. And as confirmed by the patients, their quality of life was much better when the heart failure patients, when they took empagliflozin versus the placebo on top of standard of care. Moving to the safety profile, the serious adverse events where like the SGLT2s in general and like the empagliflozin as we know it, there were no additional adverse events or new adverse events. Ketoacidosis was 0% or 0 patients, whether diabetic or non-diabetic. Hypoglycemia also was placebo-like with people with diabetes or without diabetes. Urinary tract infections numerically increased a little bit. And as we all know, all SGLT2s have genital tract infections that can be easily managed if we advise the patient properly. Bone fractures and amputations were also placebo-like, and they weren't alarming here. So to summarize it, empagliflozin met the primary endpoint and all of the confirmatory key secondary endpoints. For the patients with reduced heart failure, empagliflozin achieved a remarkable 25% relative risk reduction in the primary composite endpoint, with and 5.2% absolute relative risk reduction. It was consistent along multiple subgroups, including patients with and without diabetes at baseline and with or without ARNIs at baseline also. It reduced the first and recurrent hospitalization to heart failure by 30% in the confirmatory secondary endpoint. It protected the kidney by significantly slowing the decline in kidney function and reducing the kidney outcomes by 50%. In addition to the kidney outcomes comprising end-stage kidney disease and sustained eGFR was reduced also by 50%. And the safety profile was similar to the safety profile of AMPA, and there was no clinically meaningful increase in hypovolemia, hypotension, or hypoglycemia. So the EMPEROR reduced confirmed that the heart failure patients would benefit from empagliflozin regardless of diabetes, and this will add also to the benefits of empagliflozin regarding cardiovascular death, the heart failure, and also the all-cause mortality. And we are also we are eagerly waiting for the EMPEROR Preserved to see if the preserved ejection fraction heart failure patients will also have those benefits as the reduced heart failure patients or not. And with this, I thank you very much for your time. If there's any questions, I'm more than glad to answer. Thank you very much.
Thank you so much, Ada. Sticking to the time and finishing on time. Thank you so much. We're coming to the end of the webinar. And I would like to thank all the participants who attended with us from the beginning to this moment of time. It has been a pleasure having you. And thanks to the Emirates Diabetes Society for organizing such webinars, enlightening us with the latest developments in the field. Thank you so much. And for the CME hours, the CME will be available in 7 days. You're going to receive email, fill the evaluation form, and it will be sent to you. It is accredited by the Ministry of Health and Prevention as 1.5 CME hours. And I would like to thank the sponsors. And this webinar will be available on demand at the main website of the Emirates Diabetes Society. As you can see, it is as adsinstitute.org. And you could follow this up as well on the ADS YouTube channel. And for the coming events, could we move to the next slide? There will be coming events. Please keep it in your calendar, and it will be our pleasure to have you. And kindly pass on the message to others to make them aware about these events, including another episode of Hypertension in Depth, Part 5, and it will be on the 9th of October. And in October as well, 16 to 17 October, there will be the EDS consensus guidelines for the management of type 2 diabetes mellitus 2020, which is the Emirates guidelines for the management of type 2 diabetes. And there is the other arm of the presentation led by the young physicians, but they are at the consultant levels. As the young leader forum, there will be one in November, 18th of November, clinical pillars in the management of diabetes from the elderly, DKA, and the pump, followed by another one on the 9th of December, 2020, diagnostic and therapeutic approaches of adrenal disease. Please keep these events in your calendar, pass on the message, and thank you so much for being with us tonight. It's been a pleasure having you, and thank you so much. If you have any further queries, please visit our website at the Emirates Diabetes Society website, which is ADS website. You could easily Google it, and you will see the previous episodes, and you'll be enlightened with the coming events as well.